Good morning, everyone. We're going to get started. Welcome to the final day of our SAEM 2023 meeting. My name is Susan Promas, and I'm the Editor-in-Chief for Academic Emergency Medicine, Education and Training. I'm delighted to introduce you to 5 members of our Editorial Board. On my right is Mike Gottlieb. He's from Rush University, where he's the Associate Professor of Emergency Medicine and Director of the Emergency Medicine Ultrasound Division and Program Director of the Fellowship there. The next person is Mallory Davis. Mallory Davis is from the University of Michigan, and she is one of our fellows on the board, so we're excited to have her. The next is Lalena Yarris. She's from Oregon Health Sciences University, where she's the Professor of Emergency Medicine and Director of the Emergency Medicine Education Section and Vice Chair for Faculty Development. The next individual on the board, up here on the panel, is Christopher Nash. He's from Massachusetts General Hospital, where he is also one of a medical education fellow. And then last but not least is Esther Chen from University of California, San Francisco, where she's the Professor of Emergency Medicine, the Associate Residency Director there, and the Director of GME for Zuckerberg San Francisco General Hospital. I'm going to step down now and leave it to the panel to move you forward to go over the interesting articles that this panel chose to share with all of you. Thank you for coming.
All right, so I believe I'm leading us off here. The article is the Journal Club 3.0, a qualitative multi-site study examining new educational paradigm in the era of open educational resources, which is similar to the concept of FOAM. This is by Ting et al. And this is an interesting study. So what prompted us to pick this one is we see this. We see FOAM resources that have been rising in use, and that our learners are often faced with this, and how do we incorporate this into our practice? How do we utilize this? And how do we advise our trainees? So what they sought to do is they wanted to study what was called Journal Club 3.0, and the way they've laid it out is Journal Club 1.0, that's the model that existed in the beginning when, Osler would have a bunch of people in one room and share the one article that they could all afford to share. Journal Club 2.0, they're like, all right, let's do evidence-based medicine. Let's actually not just read the article together, let's do something more advanced with that. And then they got to 3.0, and 3.0 says, well, that's great, but what about these online educational resources, these FOAM resources that exist to analyze the articles? How do we integrate this instead of just treating it as a separate entity? So they did a qualitative study, and they looked at a whole bunch of residents at a single institution of University of British Columbia, and while they were there kind of doing the qualitative study, they identified a series of different themes. And they broke it off into 3 areas. The first one was the people, the second one was the event, and the third one was the community. So the first one was like the people, basically how did the residents actually end up using this information? There was 3 versions that existed. There was this almost anti-FOAM version that was like, it exists, I'm not gonna use it, I like to read the articles, I don't wanna be tainted by that. There's group number 2, which said, I wanna read it, but I wanna be the no spoilers group. I wanna go ahead and read the article, and then I'm gonna look at the FOAM, and it's gonna correct me, kinda like how we read x-ray images. I look at the x-ray, and then I look at the radiology report. And then we had the third group who said, well, I want to integrate it. I want to see how these kind of align together. I would meld them together as this blended type model. And then I started to look at the environment. It says, how are we going to use this? How do we utilize our FOAM resources to help us to enhance our use of journal clubs? And how do we use this to advance our knowledge? And how do we start to integrate this and looking how residents have utilized these together? And to some degree, it allows them a little bit more comfort for those who are overwhelmed by the topic to use the FOAM resources. They also looked into the Journal Club itself and realized the importance of having that faculty member there to give them support and backing to understand what they're doing. And the third thing they looked at was the broader community and the impact of Journal Club. We often have looked at Journal Club in this dichotomous split in terms of either it is something that we get together and we all hang out and have a lot of fun, or we focus on an article and we dissect it so narrowly that we just focus on the evidence-based medicine. Really, there's components of both that are really necessary. There's that melding that exists between there, and the importance of a journal club is kind of a bonding activity. And so it's worth reading the full article, but it's really interesting as we start to reflect on how we use journal clubs. And there's a lot of other really interesting pearls into there in terms of how you balance the degree and the depth to which we analyze our articles But it's a really interesting kind of take on how we do our journal clubs, how we can increase foam, and how we can help to guide our learners in the integration of foam as opposed to the separation of it.
Thank you. So the next article is titled Sex and Race, Visual Representation in Emergency Medicine Textbooks in the Hidden Curriculum by Anita Kalantari et al. This was an original contribution. The authors discussed that DEI, diversity, equity, and inclusion, is increasingly recognized as vitally important in medical education. The authors touch on hidden curriculum as a set of influences that function at the level of organizational structure and culture. This hidden curriculum really shapes the values held by trainees. It can also perpetuate and reinforce implicit bias in medical education. Implicit bias are the unconscious beliefs, attitudes, and stereotypes that people may hold regarding specific groups. And it can be really challenging to identify implicit bias and find ways to mitigate it. Historically, we have medical images that were mostly male sex and white race. The authors really wanted to examine the representation of sex and race among two textbooks. So they picked Rosen's and Tintinelli's, and they found about 2,500 images in between the two textbooks. Of these images, they found about 960 that met inclusion criteria, and then they found 845 were photos, and 114 were illustrations. And they were able to estimate race in about 877 of the cases. The white individuals comprised 78%, and non-white comprised about 14%. And they were able to estimate sex in about 362 of those cases. Males were 26% and females were 11%. They also found some pictures, about 29 pictures of clinicians, and they were able to estimate that 3 were females, 9 were males, and that the race of the physicians was about 76% white and about 14% non-white. And the authors determined that within the two primary textbooks within AEM, there was a predominance of male sex and white race. And I thought this was really interesting because I think we all kind of assume and we all talk about how these images are often white males, but we haven't actually done a study. And it's I think interesting to think about that this was fairly straightforward, fairly simple, but something that's really impactful. And I think that the authors really wanted to look at that by using these images and not having represented images in the textbooks, that it can perpetuate among test questions, lecture materials, and case vignettes, which can contribute to the structural barriers that prevent diversity and representation within medicine and within emergency medicine. The authors also discussed that this can cause downstream effects. 72% of the US identifies as white. However, ED visits for non-Hispanic, Black, or African American is 87 visits per 100. So our actual patient population that we're seeing is more African American than non-Hispanic whites. And the non-Hispanic whites were 35 visits per 100 persons. The images in these textbooks clearly don't adequately represent these demographics, and this can cause misdiagnosis in dermatologic conditions and cause delay in care. We know bias is present in other areas of medicine, like pain control, patient communication, and pediatric care. The limitations that the authors discussed in the study are difficulty analyzing the existing images based on image quality, and sometimes they have just like an arm, and so it's difficult to kind of identify exactly what's in the picture. And they only looked at 2 EM textbooks. And another point that they brought up was that the authors are assigning race and sex, so the person may not actually identify as that they were assigning that to the actual image. And so by having the lack of diverse patient representation in visual images, it really contributes to disparities. And this is an opportunity to develop specific actionable steps in dismantling the hidden curriculum against diversity in medical education and calling out implicit bias.
Next slide, please. The paper I'm going to discuss is called Faces on a Screen, a qualitative study of the virtual and in-person conference experience by Dr. Mike Gottlieb and al. And I'd like to say that Dr. Gottlieb did not get to vote on this. This paper was selected by the rest of the editorial board team, but is a fantastic paper. So this is a qualitative study using a grounded theory approach and a constructivist interpretivist paradigm that sought to explore perceptions of faculty who attended both in-person and virtual conferences during the COVID-19 pandemic. They explored the benefits and limitations of each strategy and then thought about tips for successful intervention. The themes that came up in analyzing the respondents' comments included thinking about the benefits of in-person and virtual conferences. For in-person conferences, benefits that you are all likely experiencing right now include networking, this sense of immersion or really being able to come and be present in the conference, and then a feeling of wellness that comes from that little uplift you get from coming to in-person conferences. Downsides of in-person conferences are mainly that it causes a disruption in your interpersonal life when you kind of pick up and leave and go to a conference. In terms of virtual conferences, the benefits are the well-discussed benefit of flexibility, but also accessibility in a couple of different ways. Participants felt that the attendees of virtual conferences tended to be more diverse, and the speakers were more diverse as well, and could come from places where they may not be able to travel if it were in an in-person format. And then finally, there was this concept of accessibility for the audience members in asking questions and interacting. If there was an opportunity for interaction, then it may be easier to ask questions in a virtual setting. The downside of virtual conferences are technical difficulties, the distractions of multitasking while you're at home and trying to attend a virtual conference, obvious difficulties with hands-on content, communication difficulties and feeling like communication just isn't the same on a flat screen. And then perhaps the biggest downside was the inability for connection and networking with the virtual formats that were implemented during this time. There was a discussion of hybrid options, and although hybrid options can increase access for people who can't attend in-person conferences, the participants felt that there was a dilution effect and that virtual and in-person benefits were diluted in a hybrid option. So these were structured interviews of 26 faculty, and I think it's important to note that the faculty represented a lot of diversity in terms of geographic diversity, specialty, years in faculty appointment, as well as gender. The recommendations that came out of the participant comments and the themes that emerged included, for those faculty developers that are planning virtual or hybrid conferences, to think about first optimizing technology and really making technology a primary focus of the planning process. To be creative and think beyond what we currently do in terms of opportunities to facilitate networking and engagement. And then intentionally selecting content that's particularly well suited for the digital environment. So we nominated and selected this paper for a couple of reasons. First, this is a really beautiful qualitative study. I think it's an exemplar paper for people who are interested in doing qualitative work and want to take a look at a paper where they did a really great job of it. And then second, this is a timely, relevant question as we kind of emerge from this area of all virtual and are going back to in-person, but want to still harness some of the benefits of virtual learning that we've experienced during the COVID-19 pandemic. How do we not just go back to what we did before or stick with what we had been doing, but kind of move beyond and realize the benefits?
All right, so the next one we're going to do is one of the educator blueprints, a how-to guide for survey design by Jeffrey Hill. And it's worth taking a quick moment to talk about what the educator's blueprints are. It's something that we do within our journal that is essentially a set of how-to guides for various concepts in medical education. Some examples of that would be how to make a CV, how to design good, high-quality, evidence-based or best practice multiple choice questions, how to do a program evaluation. It's a series of how-to guides to help you get started if you're interested in doing this type of work on your own. I personally use them to help me, and I would recommend if you're doing a project, if one of these exists, to use it to help guide you to do it the right way. And this one's about survey use. I think all of us in this room understand that surveys are a really valuable instrument for doing especially education work, but they can be done well and they can be done poorly. And this guide exists to help make sure that you do it correctly. Certainly, it's important to know that there's evidence-based practices in designing surveys, and that the validity of what you do is actually very largely dependent on how good your instrument is. So this guide goes through a few different questions, including making sure you start off with, hey, is the survey even the right tool for what I'm trying to study right now? So for instance, one example that was given in the article is if you're looking at a question that something such as like, is a just-in-time educational video useful for central line training or something along those lines, you can ask a survey to try and answer that question, but maybe that's not exactly the right tool to figure out how effective it is. It might be that it's better to use checklists to make sure that they're objectively improving their performance. So in other words, the survey may not be the optimal method of studying that particular question. Whereas for more poorly defined concepts such as, or hard to observe phenomena such as physician shame, this might be your actual only instrument of trying to study that phenomenon, so making sure you're choosing the right tool for the job. It's also important to note, and this is another plug for another educator's blueprint, is that there's validation of studies of surveys and instruments that can occur as well. There is a blueprint on how to do that as well, but the takeaway from this paper was if there's an instrument out there that's already been validated, somebody has done the educational work and scientific work to show that the instrument measures what you think it's measuring, it's best to try and use one that already has an evidence base behind it. So if you decide you're going to write a survey, let's talk about some of the best practices you can implement. One example would be to use positively worded questions when you're designing a survey. So for instance, if you don't have to do that double negative in your head, how often are you unable to start class on time is a little bit harder cognitively to answer than how often were you able to get to class on time. Similarly, you should try and use questions with item-specific responses. For example, like, I enjoyed the lecture, agree or disagree, is not quite as easy to get through and make mistakes and be sure that you're measuring what you're trying to measure as how much did you enjoy the lecture and give me some extent. You should try to avoid double-barreled items, which is where you accidentally ask two questions in the same question. So for instance, how effective was the lecture in hands-on instruction? That's actually two questions, and it's better to separate them out so you don't have some sort of conflation. It becomes hard to understand exactly what you're measuring. Make sure you choose the appropriate number of response options for a question. You don't want to have like a Likert scale of 11 options. If maybe 7, 6 is thought to be a little bit more optimal, it can become a little bit easier for your people who are answering your survey if you don't give them too much cognitive burden there. The last two things are make sure that you attend to formatting and layout, which means really you need to make sure you're testing it. If this is a Qualtrics survey or something similar, go through it, make sure it works on the phone, make sure it works on the computer, and make sure it's easy for your respondent to get through it. And lastly, organize your items intentionally because the order matters. If you're trying to ask a sensitive question, sometimes it's a little bit best to do that at the end. For example, you probably don't want your first question to be, hey, how often do you do illicit drugs? It threatens the validity of the rest of what you're trying to study. You want to ask the sensitive questions toward the end. That can also help you avoid some stereotype threat when you're asking demographic questions and things like that. It's about preserving the quality and integrity of your data. I think that the reason we chose this one is because, one, this is something that probably everybody in this room could benefit from, and two, this is another really good plug for a really wonderful series that our journal has on how to do some things. If you're getting started, this is a great place to make sure you're doing something right.
All right, this next paper is called Designing a Universal Tool for Debriefing, the How and What Questions by Dr. Rajendran et al. And this article is an innovations report, which is a special submission category from the journal that describes a novel strategy for addressing an educational problem. And the problem that the authors were trying to solve is how to develop the content of a debrief to facilitate deeper reflections amongst the learners after a simulation activity. Now, I suspect there are probably several educators out there in this audience that probably already know of several tools that help structure the entire debriefing process, which usually includes, setting the stage and maintaining psychological safety, as well as sort of the content and objectives of the debrief. And what is different about this tool is that it focuses entirely on the content of the debriefing so that the objectives of the simulation could be met in the shortest amount of time possible. Now, the authors were experienced in simulation education and used an iterative process to design, to test, and to refine the tool over several different simulation activities. And their final tool includes 2 sets of questions with 8 questions in each set. And these questions can be used by the facilitator during the debrief to really stimulate reflections amongst their learners. So the first set has what are called the how questions, and it really focuses on human factors. So some examples are, how did the team leader perform? Or how effective was the communication amongst the different team members? And then the second set has the what questions and really focuses on the educational objectives of the simulation. So some examples are, what are the predefined objectives of the simulation session? Or what were the thought processes that led to the observed action by a specific team member? While there were only a few outcomes presented in this report, in general, the faculty found the tool really, really easy to use and very easily generalizable to different simulation activities. And so the reason that we brought this up because we thought this tool was really interesting and effective and a little different from what we normally find that has already been published. And for future directions, the authors would really like to test the effectiveness of this tool. So I hope some of you might consider using this tool and helping the authors do a validation study. And sort of as an aside, just the innovations report is a really good category for some of the educational activities that you guys are probably already doing at your shop. And so think about it for maybe some fellows or junior faculty members, who are doing some creative things to publish in this category, because you really don't need very robust outcomes to be published, but really thinking about how did you develop your educational intervention and how did you think about it and how did you refine it over the course of however long you guys have tested it.
So the next article is a consensus list of ultrasound competencies for graduating emergency medicine residents by David Hadar et al. So this stemmed from the idea of we have ultrasound as one of our core tenets of training. And if you look at the current model of clinical practice, it has ultrasound listed as diagnostic and procedural. And that's it. And you have guidelines. You have the core AUS guideline that came out in 2008. You have the ASAP ultrasound guidelines that come out every roughly 6 years, last one being 2016. And those give a list of here are some of the kind of the general senses of what we should be covering. But we have, almost 300 residency programs in the United States. Each of them has to have come with an ultrasound training program. And wouldn't it be great if we all knew what needed to be covered? If we could come to some consensus, some sense of what should actually be covered for ultrasound training. And that's what prompted them to do this. And so this is a modified Delphi study. And they began with, as any good study should, with the literature search. So they did a formal literature search. They looked through and they identified, both the guidelines that exist to see what people have laid out as common applications. And then they went ahead and they also looked at the literature to see what other applications seem to arise from there. And they put together this massive list. They assembled 15 people and they built their kind of, Delphi panelists. And they were intentional in this in a few different areas. So they wanted to make sure they had diversity of the panelists. They had, a relative balance by sex. They had a relative balance by geography and by practice type. Because it's a very different type of application if you went, for example, to an academic, hospital that has a dedicated ultrasound fellowship. You're like, yeah, everyone needs to know everything about ultrasound that's ever existed in the history of time. We're going to be doing carotid flow studies. And then you go to the community and they're like, carotid what? And it's not going to match, right? So they also include people who do community hybrid, who train residents. They include people at county hospitals. And they wanted to have this kind of breadth of Delphi to see what should we actually learn? What are the core competencies or the core areas that you need to make sure everyone learns in? And so they structured their Delphi, and they had, the way they had done their Delphi is they used a rating scale from 1 to 5, which ranged from 1, not very important, to 5, very important. Good use of a Likert scale, following best practices in survey design. And they then went through and they had everyone vote on this, and all 15 members vote. And what they used as a threshold is they said greater than 80%, which is pretty common in the Delphi literature. Greater than 80% threshold of an either important or very important on the Likert scale would count as high agreement, and they would move it forward. So they had a whopping 359 applications of things. So people had to go through 359 different items and go each one through 5. And they went through them all, and they voted on them. And as they went through them on round 1, everyone completed, which is great. It's always a good start if everyone's actually completing the survey you have them do. And they had agreement on 195 of them. So that means 195 of them went forward, The remainder had to be revoted on. They discussed, they revoted, they went through the process again, and by the time they got to round 2, they reached their final consensus with their total numbers being ended up being 209. And so those are kind of total lists, and I'm not going to read through all 209 because the talk is only so long, and at some point you all will leave. So I'm not going to have you sit through 209. It's worth looking at the list to get a sense of what the spectrum is, but probably in a more global sense of it. They broke it down by applications. They said aorta, here are the things in the aorta you need to look at. Cardiac, here's the list of things in cardiac. And they also realized some topics are probably a little bit more advanced or esoteric for the average resident. So they looked at things that are like, you know what? Not every resident needs to understand airway ultrasound. Now, personal bias, I think they should, but that's what they decided as a Delphi, so they started to siphon that out. And I think it's useful for a few different areas. And this is kind of what prompted us to look at this study. One, it's a good example of a Delphi model, and to think about Delphi as a model for developing consensus, to understand how you can, when there isn't a clear, distinct yes, no, and you're trying to arrive at an outcome like this, it's a good use of a Delphi model or a modified Delphi model and to see how they did it. Second one is if you're involved in any form of resident education, to see what the experts have recommended is what they should be covered. Gives you a sense of the breadth in both directions. And I think for those who are in ultrasound leadership roles or who are interested in kind of getting involved with ultrasound groups, it gives you a starting framework of if you're going to build a curriculum, what should you cover? And for the residents reading it, it can give them a sense if their program may or may not have read this article, to say, if I'm a resident who wants to graduate with a sound foundation in ultrasound, what are my gaps and what do I need to cover? And so I thought this is a really nice kind of opportunity for learners, for faculty, and for research, for education researchers alike, to learn from both the product and the methods.
All right, our next article is titled Targeted Organized Teaching Scripts in the Pediatric Emergency Department by William Sokoloff. This is a new ideas in bedside teaching, which is a shorter submission on educational case reports. And this is a nice way to kind of get out into the world if you're doing an innovative type of teaching style or you're doing something different at your shop, a way to kind of get it out in the literature so that other people can take it as an example and potentially use it at their own place of where they work. So we all know learning within a pediatric emergency department or any department has traditionally been on precepting and self-directed learning. There's always challenges such as inconsistent resident exposure to key pathologies, faculty with limited educational resources and training, and there's always increasing time constraints, making education really challenging. Teaching scripts were suggested as an alternative by the authors, and they look at those as brief and focused teaching moments between the educators and the learners. And what they do is they utilize micro-learning and just-in-time teaching. This really also has a catchy TOTS. I don't know if anyone noticed the PEM, so snazzy. And they developed these teaching scripts for 10 core content areas in pediatric and AEM board exams. And these were identified as knowledge gaps from PEM and from emergency medicine. The scripts were bulleted outlines of high-yield information that could quickly be presented in 3 to 5 minutes. The faculty were introduced to the TOTS during a faculty meeting. I don't know why I always have to give it a little TOTS. The scripts were printed on large laminated cards, and they were kept at the attending workstation so they could easily be referenced. Residents who were rotating through the PDD were assessed 3 months before and 3 months after the intervention. And the pre-intervention survey was 19 residents, and post was 28 residents. The TOTS were used by about 2/3 of attendings, and acetaminophen toxicity and intussusception were the 2 most highly used topics. 64% of the residents received at least one teaching topic, and about 80% of residents and 80% of faculty responded that they would be quite or extremely interested in expanding these to other topics. Learner satisfaction also increased following the implementation, and about 63% were very satisfied with the amount of learning that they got on shift, as compared to about 42% of residents that did not receive any TOTS while on shift. I think that this is a good way to look at something that could easily be done in the peds world or in the adult world to kind of increase your ability to teach on shift and have kind of a standard teaching script that I think all of us are medical educators probably in this room and are passionate about it, but for those that maybe this doesn't come as naturally, to kind of give people something that they could easily reference while on shift. Faculty from the study felt that they were able to teach somewhat or much more with TOTS, about 57%, and they all found that TOTS were able to increase teaching and satisfaction with learning. So something to think about, and then we could come up with a catchy, like, adult, not TOTS, I don't know, I'll think about it.
I work mostly in the peds ED, and when I saw that, I really just thought of tater tots. I didn't get like the small children reference for a little while. So, but still,
That's good
lovely,
too, tots,
yes. The next paper I'm going to discuss is called "Everybody in this Room Can Understand: A Qualitative Exploration of Peer Support During Residency Training," done by Dr. Arthi Jain and her team. And one of the things I love about qualitative studies, there's so much to love, but the titles are so beautiful. So let's just take a moment to appreciate that. So the aim of this study was to really understand resident perceptions of peer support groups. And this author team looked at an existing peer support group at their institution that was comprised of residents from PGY1 to PGY4 years who were paired with alumni, resident facilitators, and mental health professionals. They did a reflexive thematic analysis after conducting focus groups. And they were able to do focus groups with a total of 15 residents with 3 separate focus groups. And then they did a 4th focus group with 4 facilitators that was done for triangulation of data and themes. There were basically 4 main themes that came out in terms of exploring what was really happening in these peer support groups. The first was this theme of a more experienced other. So the more experienced other in these groups were the senior residents or the alumni facilitators, and the participants really felt that this was truly beneficial to them to provide guidance. The second was that there was an insider benefit, and they really felt that there was a feeling of support and camaraderie by having other residents either currently in the program or just graduated as the facilitators. They felt that the beneficial addition of the mental health professional was a plus. They did not feel that faculty would qualify as insider benefits in terms of being a part of these focus groups, and really liked the senior resident and alumni facilitator structure. Although the senior members of the team could give helpful advice and kind of tell them what was to come, there was a theme that came up in terms of things that would be discussed as coming up that was anxiety-provoking to them. So for example, if the fourth years were talking about, gosh, I'm so glad I'm done with second year, the first years would sometimes have this sense of anxiety, and it could be not as helpful to hear that, the negative kind of what's to come. The third theme was psychological outcomes, and really just this sense of normalization and the benefit of processing things together. And then finally, a sense of connection and belonging, and feeling part of a greater purpose and part of a group. Although there were themes that came up in terms of maladaptive coping strategies that can sometimes occur during peer support groups, and also when things come up that cannot be solved by that group as a potential downside, overall these were felt to be very beneficial by the residents. So the reason that we nominated and selected this study is because it's also a well-done qualitative study. It looks at a question that's really well-suited to qualitative methods. But one of the reasons that I really appreciated this study is because it goes beyond creating an intervention, peer support group, or even just evaluating that intervention and aiming to turn that into scholarship. But the authors really explored what was happening in this intervention in a way that would be transferable and relatable and applicable to other residencies and even other specialties. So think about that when you're studying your interventions, about going beyond program evaluation and really trying to create new knowledge that can be applied to lots of similar educational questions in other settings.
All right. So the next article we're going to talk about is The Cost of Free Open Access Medical Education, everyone knows as FOAM, an economic analysis of the top 20 FOAM sites by Matthew Lee et al. The context of this article is sort of, especially within emergency medicine, FOAM has taken a central role in education and to at least a certain extent in education scholarship and general scholarship. And really the way that we learn in this specialty doesn't just come from journals, it's from blogs and podcasts and newsletters. And so how do we make sense of the value of that? For instance, I could start a website today and I could publish something on it. It's really hard to know exactly what that would mean in terms of quality, but certainly everyone in this room can think of examples like Life in the Fast Lane, AEM, of these powerhouse sites that have really positively improved, I think probably truly the quality of patient care in this country. And how do we view those? And this was one attempt to try and answer that question by looking at an economics analysis, which I thought was a really very interesting approach. I don't know that value is always calculable in dollars and cents, but this is a really interesting way of trying to value what is being done on these websites, and it creates, I think, a tangible sense of what's being done. If you can imagine, someone who puts a lot of time and effort into foam might feel as though their efforts shouldn't be in vain, and something like this gives a more tangible way for someone on a promotions and tenure committee or your chair to understand the value of what it is that you're doing. And so how did they do this? They looked at the top 20 foam websites in emergency medicine that were identified kind of through a variety of methods, including personal communications, word of mouth, that then led to a purposeful snowballing technique, and then lastly verifying with Google search to make sure that there weren't other sites out there that ought to have been included. And then they calculated who were in the top 20. They're trying to limit the analysis to the top 20 for this article. And they looked at the Alexa rankings. Alexa is not like the one that you talk to in the corner of the room. In this case, it's like it's an old, now being deprecated source of information to look at web traffic, so you can see who are indeed the top 20 sites. From there, they then gathered traffic data from a company called SEMrush, and then they took two approaches to answering this question. If we're going to try and put a dollar value on what it is that these websites are accomplishing, there's two ways that they chose to approach it, which I thought were both very clever. One is, how many articles does that site produce? Multiply that number of blogs that they publish by the average cost of accessing an article. So if you think about going to a typical site, most of us have institutional access, but if you didn't, you'd pay $35 to rent an article. So $35, we'll say that's the value of that article, multiply it by the number of posts you've had on your blog, and that gives you a value. And so that median value for the top 20 sites was about $2,300 per year. The other one is to look at traffic analysis, meaning how many eyes does this get in front of? And then what they did was to extrapolate based off of other similar sort of, we'll say, like industry benchmarks and it's a little bit nebulous exactly how they got this finite value because they had a third-party analyst go through it, and they extrapolated from health and beauty domains and medical domains from other similar websites, and these experts would say, well, this much traffic is equated to this much value, whether for ad revenue or whatever else. So they decided that every 1,000 page views is worth about $18.50, and every 1,000 unique visitors, which is a slightly different measurement, is about $22.50. The median value for the top 20 sites is about $22,000 a year. So again, either way how you slice it, there's really substantial value to what's going on here, including if you're looking at it from an economic perspective, all the way up to if you're looking at like the page views for Life in the Fast Lane, we're talking about like millions of dollars. So like what they do is adding real true value to our community. There were some limitations. You have to make some assumptions in a study like this, so we're drawing value from people who are visiting more so than what is being generated, but it's at least a way of looking at it. It does somewhat potentially value some of the lesser known sites, and it's not clear to me that someone who puts the time and effort into a site that gets less traffic is necessarily less valuable, but this analysis wouldn't have accounted for that. Similarly, there are other parts of the scholarship that weren't included, such as the social media index, there's the new digital impact factor, that weren't accounted for in this, but nonetheless, they all kind of add to the conversation in a similar way. Lastly, Alexa, that is going away, so there's going to have to be new ways to account for traffic in the future. Why was this chosen? This is an interesting conversation, and this was one, I think, rather innovative approach to try and chip away at some of it and try and understand this better. Certainly, I bet everybody in this room uses these sites, and many of you probably contributed to it, and it's helpful to make sure that the value of what's being done is recognized.
Okay, this is our last article, and this is a really fun one. The title of this article is Avocado Toasted, Mythbusting Millennials, Generation Z, and Generational Theory by Schnapp et al. And this article is published as a really fun educational download, and this is a submission category for the journal that provides just a quick snapshot view of an educational concept that's relevant to teaching and learning in emergency medicine. It's what I would call a quick read because it's only 2 pages and it's really easy to just learn something that's publishable. And this particular snapshot includes an infographic that highlights 3 stereotypes of millennials and Gen Z learners and recommends specific teaching strategies for teachers who are often of a different generation to overcome issues in the clinical environment that might be falsely attributed to younger learners. And I'll share one example from this article. So a common trait attributed to younger learners is that they frequently need praise or recognition for their efforts, or maybe that they might resist guidance on their performance. And while there is no evidence to support emotional fragility as generational, faculty might make this assumption about younger learners and end up giving maybe positive but insincere feedback, or hesitate to give constructive feedback at all. Now, the authors recommend some best practices for giving necessary corrective feedback, such as offering timely and specific advice after a clinical shift, engaging in an educational alliance with your learner at the beginning of a shift, or maybe even longitudinally by mentoring learners to address maybe individual challenges with receiving feedback. So I'll just mention that the other 2 stereotypes that the authors present that commonly are attributed to younger learners are that they are technologically obsessed, with phone and computers, and have a very short attention span, at least compared to older learners. And the authors in this article recommend some specific strategies to address these attributes, which might be falsely attributed to younger learners, and really to improve bedside teaching and use some of these characteristics to better connect with their learners. So, and with that, on behalf of just the panelists and the entire editorial board at AEM Education and Training, we wanted to thank you all for coming and for being such a great audience. So.
We have a few minutes left, so if any of you have questions for members of our editorial board, please feel free. We're here to help you. You just wowed them, you guys. They're speechless. Okay, well, safe travels home, and thanks for coming, you guys. Appreciate it.